Assalamu alaikum. I'm Professor Dr. Hayder Mubarak. I will present today the third lecture on anatomy of the thorax. The first topic in this lecture is in regard to joints of the thorax. The bones forming the thoracic cage are connected by many joints, including number 1, mandibulosternal joint, which is the joint between the mandibulium of the sternum and the body of the sternum. It is a secondary, the type of this joint is a secondary cartilaginous joint, and it forms an angle between the mandibulium and the body of the sternum that could be felt on the surface anatomy of the chest wall. This angle is called sternal angle of Lewis. The second joint of the thoracic cage is the costovertebral joint. This joint is between the facets on the head of the rib and the body of the vertebra. It is a plain synovial joint. This joint is supported, as you can see, by radiate ligament, which is formed of a 3-part and therefore sometimes called as triradiate ligament. The third joint is the costotransverse joint, which is between the tubercles of the ribs and the anterior aspect of the tip of the transverse process of thoracic vertebra. This joint is also a plain synovial joint and is supported by costotransverse ligament, which are 3 parts: medial, lateral, and superior. Number 4 is the costochondral joint, which is between the ribs and the costal cartilages. This joint is a primary cartilaginous joint. The fifth joint of the thoracic cage is the chondrosternal joint, which is the joint between the costal cartilages and the sternum. And as you know, such chondrosternal joints occurs between the costal cartilages of the ribs from number 1 to number 7, that are called the true vertebrosternal ribs. These joints, the chondrosternal joints, are synovial joint except the first one, the first chondrosternal joint, which is a primary cartilaginous joint, while all the others are synovial joints. The interchondral joints is represented by the joint between the costal cartilages of the vertebrochondral false ribs, in which the costal cartilage of the 10th rib is articulating with that costal cartilage of the 8th rib, and the 8th costal cartilage articulate with the 7th. These interchondral joints are synovial joint apart from the last one, which is between the costal cartilage of the 10th and 9th rib, that is a fibrous joint. Finally, the intervertebral joint. The intervertebral joint is the joint located between the body of the vertebra. It is a secondary cartilaginous joint. It contains an intervertebral disc. This intervertebral disc is formed by a central gelatinous material, which is called the nucleus pulposus. This gelatinous material is surrounded by annular fibrous tissue, which is called annular or annulus fibrosus. And the intervertebral joint is similar to any other intervertebral joint in the neck, in between cervical vertebrae or the lumbar region, and it is supported posteriorly by ligamentum flava that extend between the lamina of the vertebrae, and also supported posteriorly by the posterior longitudinal ligament and by the interspinous ligament and supraspinous ligament, while this joint is supported anteriorly by the anterior longitudinal ligament. That's all about the joints of the thorax, and as you can see, I'm presenting the main issues in the joints regarding the type of the joint, articulating bones, and some of the ligaments uh, in consideration to what is important in terms of clinical applied anatomy. The other topic in this lecture is the mechanism of respiration. Joints of the thorax moves in order to help in breathing, and breathing or respiration is as everybody know is two phases: inspiration and expiration. During inspiration, the thoracic wall moves so as to increase the cavity of the thorax. This is to increase the volume of the cavity of the thorax, and such an increase in the volume of the cavity of the thorax will create a negative intrathoracic pressure, and such an negative intrathoracic pressure will lead to suction of air into the air. This expansion of the volume of the thoracic cavities occurs when the obliquely lying ribs, you know that all the ribs are obliquely lying, are elevated upward by the action of the muscles of respiration, which are extrinsic and intrinsic muscles of the thoracic cage. So what is happening during inspiration, that the obliquely lying ribs are elevated upward during inspiration by the action of the respiratory muscles, which are the extrinsic and intrinsic muscles of the thoracic cage, and this elevation of the ribs will lead to expansion of the volume of the thoracic cavity, and thus creating negative pressure for suction of air into the lung. While relaxation of the extrinsic muscles will lead to elastic recoil of the thoracic wall, and thus the volume of the thoracic cavity is decreased, and so the lung tissue will be compressed, and thus the air will be expelled out of the lung tissue due to this passive elastic recoil during expiration. So the main issue of mechanism of respiration is the issue that explains why the volume of the thoracic cavity is increased during inspiration. What is happening when the obliquely setting ribs are elevated, and thus or subsequently resulting in increase of thoracic cavity? Actually, the explanation of this increased thoracic cavity, volume of thoracic cavity, could be explained in terms of 2 points. Number one, the pump handle movement. The vertebrosternal ribs, mostly when they will be elevated, the anterior end of these ribs, including the sternum, will also be elevated. Such an elevation of the anterior end of vertebrosternal ribs would lead to increase in anterior-posterior diameter in a manner similar to elevation of the handle of the pump, and that's why there will be an increase in anterior-posterior diameter of the thoracic wall. And also, or in addition, the vertebrochondral ribs, which are the 8, 9, 10 ribs, also during inspiration, the mid-lateral parts of the curved vertebrochondral rib will also be elevated, and this elevation of the mid-lateral curvature of the vertebrochondral ribs lead to increase in transverse diameter in a mechanism similar to increase or elevation of the bucket handle, and so this movement is called bucket handle mechanism. In addition to these, the diameter descends down during inspiration, and thus increasing the vertical diameter of the thoracic cavity to help in breathing or inspiration. So all of these, bucket handle, pump handle, and vertical diameter increase movement will occur by action of the muscles of inspiration or respiration, including the diaphragm, and Relaxation of this muscle will lead to elastic recoil, and thus the size of the thoracic cavity will decrease, compressing the lung, resulting in expiration and expulsion of air from the lung. This is all about the mechanism of breathing or respiration. The next topic will be about pleura. And the pleura should be considered as part of the thoracic cavity. We have to define that the pleura is the bilateral cavity of the thoracic, inside the thoracic wall. And we can say that the thoracic cavity is formed of right and left bilateral pleura, while in the midline there are many structures including the heart, the great vessels, the esophagus, trachea, the main respiratory and digestive organs, and the cardiovascular organ. The midline structures are described as being the part of the cavity, of the thoracic cavity, which is called mediastinum. So the thoracic cavity generally is formed of a midline part, which is called mediastinum, and bilateral pleural cavity. This is number one. Number two, in which we have to describe the pleura. The pleura is a membrane, and as this diagram is showing, the membrane has two parts. Part which covers the lung and is firmly adherent to the lung, and this part is called visceral pleura, which is covering the lung and having the same autonomic nerve supply of the lung. Thus, it is pain insensitive because the autonomic nerves carries poor sensation or non-sensation. This is the first part of the pleura, the visceral pleura, which covers the lung and firmly adherent to the lung. The other part is the membrane or the pleura lining the wall of the thorax, which is called parietal pleura. And this parietal pleura is supplied by spinal nerves, the same nerves of the thoracic wall, and thus the parietal pleura is pain sensitive or sharply sensitive to pain. As you can see, the parietal pleura not only lines the thoracic wall but also covers the superior surface of the diaphragm and covers the apex of the lung and covers the sides of the mediastinum above and below the mediastinal structure or mediastinal cavity. And accordingly, we can divide the parietal pleura into four parts. Number one is the costal pleura, which is the pleura lining the thoracic wall, including the ribs and intercostal muscles. This is the costal pleura. The second part is the diaphragmatic pleura, which is the parietal pleura covering the upper surface of the diaphragm. And the third part is the mediastinal pleura, which is the parietal pleura covering the sides of the mediastinal structures. And the cervical pleura, which is the pleura covering the apex of the lung, and it extends into the root of the neck. Sometimes the cervical pleura is called copula. The parietal pleura, which is formed of these four parts, diaphragmatic, mediastinal, cervical, and costal pleura, shows reflections, that means angulations, in which one part of these parietal pleura is continuous with the other. For example, in this region, you can see this angle represents a continuity between the costal pleura and diaphragmatic pleura. And so we have now to discuss reflections of the parietal pleura. The first of these reflections is the anterior reflection, which is called sternal reflection because it lies behind the sternum. This reflection or angle is a reflection between the costal pleura and the mediastinal pleura. It is called sternal or anterior reflection. The other is the posterior reflection, which is the vertebral reflection because it is on the sides of the vertebra. And again, this reflection or this angle is a reflection which is a continuity between the costal pleura and also the mediastinal pleura. The third reflection, which is the inferior reflection, which is this one, is the reflection of the costal pleura with the diaphragmatic pleura. The parietal costal with the parietal diaphragmatic pleura. What is important about these reflections is that you may be able to draw the line representing these reflections on the chest wall as part of studying the surface anatomy of the thoracic wall, and this line of reflection which could be drawn is important clinically for clinical application, as we will explain soon. So let us follow the line that could be drawn to the sternal reflection, and I want you to remember that this is the sternal reflection, the anterior one between the costal and mediastinal pleura. I will draw on the chest wall the line for this angle, for this reflection. So if this is a chest wall and I want to draw the line of anterior sternal reflection, I will start, of course, you know we have a right line and left line for the right pleura and left pleura. So I will start on right and left side at a point which is the sternoclavicular joint on the right and left side. This is the beginning. Next, I will draw a midpoint at the sternal angle at the level of the second costal cartilage, which is for both the right and left side, the right and left reflection. And this second point will be in continuity. I will draw a line from sternoclavicular joint to this point and sternoclavicular joint to this point. Next, also, I will draw a midpoint at the level of the fourth costal cartilage, also for the right and left side. More inferiorly, the other point for the left sternal reflection will be different from the right drawn for the right sternal reflection. From this point, the midpoint at the fourth costal cartilage, the sternal reflection on the right side will be connected. The line of sternal reflection on the right side will connect this point at the fourth costal cartilage with a midpoint at the xiphisternal joint. This is for the right sternal reflection. While the left sternal reflection will be the line extending from this point, which is the midpoint at the fourth costal cartilage, to this point, which is the sixth costal cartilage, away from the midline, on the left side of the midline. So about that, I had finished the line of sternal reflection for both the right and left pleura. Next, I will draw the line of reflection of the vertebral, or let's say the costal reflection. First, I will remember you what is the costal reflection. The costal reflection is the inferior reflection, which is this one, between the costal parietal pleura and the parietal diaphragmatic pleura. I will draw this line. The line of a costal reflection will be by joining the following points. I will put on point just on the chest wall, and the line connecting this point will be the line of representing the costal reflection, just like the way we had drawn before a while the line of reflection of the sternal reflection, points that are connected. So I will draw a point to draw the costal reflection, the inferior reflection. Of course, I have to start from the lower end of the sternal reflection. So on the right side, I will start from the middle of the xiphisternal joint, while on the left side, I will start from the sixth costal cartilage on the left side of the midline. These 2 points on the right and left side will be connected with a point which is the 8th costal cartilage at the level of the mid-clavicular line. And more laterally, the other point that should be connected is the 10th costal cartilage or 10th rib in the mid axillary line. So first it will be the 8th rib in the mid clavicular line, and then the 10th rib in the mid axillary line, and finally the final point will be the point at the 12th rib on the right and left side, 2 centimeters from the spine of T12 vertebra. So finally this is the final posterior point to draw the line of costal reflection. Then I have to draw the line of vertebral reflection, and also going back to the same diagram to remember you what is the vertebral reflection. This is the vertebral reflection. It is the reflection of the costal pleura with the mediastinal pleura. In order to draw the line of this vertebral reflection, I will use these points, which are the posterior ends of the line of the costal reflection at the 12th rib, 2 centimeters lateral to the T-spine, T12 spine. These two points will be connected up to a point which is 2 centimeters lateral to the spine of C7 vertebra. And this is all about the line of vertebral reflection. In addition to these surface anatomical lines for the reflections of the pleura, I can draw the copula, which is the cervical pleura, in form of a curved line above the medial 1/3 of the clavicle, extending to about 2 centimeters above the medial 1/3 of the clavicle into the root of the neck. What is important about these reflections? First, I have to say that the first clinical point, that the pleural cavity, which is the cavity between parietal and visceral pleura, as this figure shows, the cavity, the pleural cavity, is the pleural space between parietal pleura and visceral pleura, is normally filled with a little amount of a fluid, and it is potential cavity. But sometimes this cavity is filled by more than a thin film of a fluid. Actually, this film of a fluid is always at a negative pressure in regard to the atmosphere. And so, for example, if there is a wound into the thorax, or a rupture of the lung, the negative pressure of the pleural cavity will lead to entry of air, either from outside or from the lung, into the pleural cavity. So air in the pleural cavity is called pneumothorax. And sometimes this wound or rupture of the lung will lead to accumulation of blood into the pleural cavity. So it is called hemothorax. And in heart failure, renal failure, there may be a fluid into the pleural cavity, which is called pleural effusion. Inflammation of the pleura leads, or lung, leads to accumulation of pus into the pleural cavity, which is called empyema. So, in regard to the lines of reflection and their significance, sometimes we may have a wound for surgical purpose, and this wound may lead to injury to the pleura and the pneumothorax. For example, you know this point? The point on the right side of the xiphisternal joint. Here you can see that the pleural reflection, the line of pleural reflection, is reaching to this angle, and if a surgeon is working around there below the right costal margin for example, for operation into the liver or removing gallbladder or else. If the wound of the surgeon extends up into this angle, the wound may injure the pleura in this angle, the angle on the right side of the sternal joint, and thus air will enter from outside into the pleura, resulting in a pneumothorax. Again, if there is an operation posteriorly at this angle, between the angle of the angle between the 12 rib and the vertebral column, you can see here also that the line of pleural reflection extending below the costal margin or below the ribs in this angle between the 12 rib and the vertebral column, for example, during operation for the kidney. So the wound here may perforate the pleura, resulting also in a pneumothorax. And this is what is described here, that the pleural cavity extends below the costal margin on the right side of the sternal joint, and also it extends on both sides of the costo-vertebral joints, and thus during abdominal incision for surgical purposes you may injure the pleura here, resulting in suction of air and pneumothorax. These are an X-ray for the clinical topic. This is a left pneumothorax. You can see that the pleural cavity is not potential here. It is a large cavity filled with air, and because the pressure here is not negative, so it is high pressure that pushes the lung, leading to collapse of the lung and difficulty in breathing. This is an X-ray of a right-sided pneumothorax. This is a left-sided pneumothorax. You can see here that the left pleural cavity on X-ray is very dark black, because here the air makes the dark black color, while here on the left side you can see the normal marking of the lung. Again, this is a left-sided pleural effusion, a fluid filling the pleural cavity. You can see here this is normal right-sided pleural cavity, and this is a right-sided pleural effusion where we are trying to aspirate the effusion into a jar. An important point during chest X-ray in regard to the costodiaphragmatic recess. This angle, which we had in anatomy, call it as the costal reflection between the costal and diaphragmatic parietal pleura, is very important normal mark that should be examined during examination of posterior anterior chest X-ray. If this angle is absent, as in this figure, it indicates that there is a little amount of fluid into the thoracic cavity, into the pleural cavity. So we must always look for the angulation of this costal reflection. And actually, as a landmark in radiograph, it is called costodiaphragmatic recess. So there must be always a sharp angulation at the costodiaphragmatic recess, which is the costal reflection. You can see here that the bilateral costodiaphragmatic recess is clear, so it is a normal chest X-ray, while here the right-sided costodiaphragmatic recess is filled with thin amount of pleural effusion. Again, in addition to the reflections seen in between the parts of the parietal pleura, we may find a reflection here between the pleura that covers the lung, which is called visceral pleura, and the pleura lining the sides of the mediastinum, which is mediastinal pleura. This reflection is located above and below the root of the lung and is called pulmonary ligament. It is shown here. This is the lung, and this is the root of the lung containing the bronchi, pulmonary artery and vein. And you can see that the root of the lung is surrounded by a reflection of the visceral pleura to be in continuity with the mediastinal pleura, and this reflection is called pulmonary ligament. This pulmonary ligament have a large size, larger than the root of the lung, in order to allow venous drainage from the lung, and also to allow the slight degree of movement of the root of the lung. As we said at the beginning of the description of the pleura, that the visceral pleura is supplied by the same nerves, autonomic nerves of the lung, which is sympathetic and parasympathetic, and this visceral pleura is firmly adherent to the lung, and so because it is supplied by the same nerve of the lung, autonomic, it is poorly sensitive to pain or non-sensitive to pain. While the parietal pleura is pain sensitive because it is supplied by spinal nerve. The details of spinal nerve supply to the parietal pleura is as following. The costal and the periphery of the diaphragmatic pleura are supplied by the intercostal nerves, while the mediastinal pleura and the central part of the diaphragmatic pleura are supplied by the phrenic nerve, which is a branch from the cervical plexus having the root value, which are spinal nerve C3, C4, and C5. This is mostly all about the anatomy of the pleura. Next, the next topic will be the lung, the anatomy of the lung. As you can see in the figure, the right and left lung are conical structures. They have an apex lying at the root of the neck, both having a surface which is related to the chest wall, to the ribs, and so it is called costal surface. And in cadaver, the costal surface shows grooves for the ribs. Of course, this is only a feature seen in cadaver, it is not seen in living. In addition to the apex and the costal surface, the lung also, the right and left lung have medial surface, which is this one. This is one on the left, and this is the medial surface on the right. And as you can see that this line divides the medial surface into posterior part and anterior part on both sides. This is the posterior part of the medial surface, and this is the anterior part of the medial surface. The posterior part of the medial surface is related to the vertebra, and thus it is called vertebral part. It is rounded, related to the paravertebral gutter, and sometimes is called as the posterior border. While the anterior part of the medial surface is related to many structures lying in the mediastinal cavity on both right hand side and left side. In addition to the apex, costal surface, and medial surface, the lung also has an inferior surface which is called diaphragmatic surface that is related to the diaphragm. You can see here the medial surface also with the structures related to the anterior part of the medial surface on the left side, and this is the mediastinal structures related to the anterior part of the medial surface of the right side. And you have to remember these structures in a practical anatomy. The inferior surface of the lung, which is related to the diaphragm, is considered also to be related to structures below the diaphragm, which are the liver on the right side and the stomach and spleen on the left side. Regarding the borders of the lung, we had said that the posterior part of medial surface, which is vertebral part, sometimes is called as the posterior border or the vertebral border. So opposite to that, this is the anterior border, and you can see that the anterior border of the lung is sharp both on the right and the left side, or thin. We can say sharp or thin. And we can see that the anterior border of the left lung is deviated inferiorly in the region where the heart is lying, and thus deviation forms a notch for the heart, which is called cardiac notch. This notch deviates from the midline laterally and to the left at the fourth and fifth intercostal spaces. And you can see that this notch then curved back toward the midline and to be in continuity with the inferior border of the lung. And this reflection represents a tongue-like structure which is called lingula of the lung. You can see that the right lung is formed of three lobes: superior lobe, middle lobe, and inferior lobe, while the left lung is formed only of a superior and inferior lobe. And again, you can see that the superior lobe of left and right lung and the middle lobe of the right lung are lying mostly anterior, while the inferior lobe on both sides, the right and left, lies mostly posterior. And you can see that the superior and inferior lobes of the left lung is separated by an oblique fissure. This fissure is also seen on the medial surface, not only on the costal surface. And that this oblique fissure separates the middle from inferior lobe, while the middle on the right side, while the middle and superior lobe on the right side are divided by a horizontal fissure. So during auscultation, during chest examination with a stethoscope, which is called auscultation, if there is a sign, for example, abnormal sounds of breathing anteriorly, and in that case, if it is anterior and abnormal sound of breathing anteriorly on the left, you will say that there is a disease in the upper lobe of the left lung. But if there is abnormal sounds anteriorly and on the right, this abnormal sound indicates a disease either in the upper or middle lobe, while an abnormal breathing sound heard posteriorly by the stethoscope during auscultation will be an indicator of a disease in the lower lobe of the lung on the left and right side. Each of these lobes of the lung, the upper and lower on the left side, upper, middle, and lower on the right side, is formed of many segments that are called bronchopulmonary segments. These bronchopulmonary segments, as you can see in the figures, in this figure, have the same name of the bronchial segments supplying them. And each of these bronchopulmonary segments represent a functional unit of the lung, in which if a disease occurs in any of these segments, you can remove this segment without affecting the functions of the other segments, because each of these segments is separated by a septum of fibrous tissue, and it has its own segmental bronchus, its own artery, its own nerve, its own vein, its own lymphatic. So you can remove this segment, for example, if it is diseased, without affecting the function of the other segments. You can remember the name of these segments from this table. And you can see that the right lung shows totally 10 segments. The upper lobe contains 3, the middle lobe contains 2, and the lower lobe contains 5. While the left lung contains 8 segments, in which there is 4 segments in the upper lobe and 4 segments in the lower lobe, and these are the name of these segments. Before a while we had discussed the pulmonary ligament, which is a line of reflection of the visceral pleura to be in continuity with the mediastinal pleura. And we said that this pulmonary ligament surrounds the root of the lung. So the root of the lung is seen on the medial aspect of the lung, at the medial surface of the lung, specifically in the anterior part of the medial surface. The pulmonary ligament surrounding the structures lying at the root of the lung, or called hilum of the lung. These structures include the bronchus that lies behind, the pulmonary artery that lies above the bronchus, and 2 pulmonary veins antero-inferiorly. So it will be a bronchus behind, an artery above, and 2 veins antero-inferiorly. In addition to these main structures lying at the root of the lung on both right and left side, this is the figure for the root of the lung on the left side, while this is the root of the lung on the right side, in which we have a bronchus behind, an artery above, and 2 veins antero-inferiorly. There are many small structures including bronchial vessels, lymphatics, and autonomic nerves. And in addition, you have a bronchus above the main bronchus on the right root of the lung. Thus, this additional bronchus called epiarterial bronchus, because it lies above the artery. So in the root of the right lung, the hilum of the right lung, you have a bronchus behind, an artery above, and 2 veins antero-inferiorly. But in addition, you have an epiarterial bronchus above the artery. Such an epiarterial bronchus is not seen in the root of the left lung. It is only a feature of the right lung. If you just remember that before a while we had drawn lines of reflections of the pleura, of the parietal pleura. And now I will draw lines of the surface anatomy of the lung. Starting with the apex of the lung. The apex of the lung could be drawn just like the drawing of the line of the copula, the cervical pleura, simply as a curved line above the medial 1/3 of the clavicle, extending 2 centimeters above the clavicle and to the root of the lung. Next, I will draw the surface anatomy of the anterior border of the lung. The anterior anatomy of the surface anatomy of the anterior border of the lung will be drawn by a line connecting points which are the same points drawn for the sternal reflection of the pleura, in which on the right and left side we will start from the sternoclavicular joint on the right and left side. Then for both sides it will be the midpoint at the level of the sternal angle, which is the level of the second costal cartilage, down to the midpoint at the level of the fourth costal cartilage. These are the same points for the sternal reflections of the pleura, but here there will be a slight difference from the line of sternal reflection of the pleura. The line of sternal reflection on the right side of pleura will extend from this midpoint at the fourth costal cartilage to the midpoint of the xiphisternal joint on the right side, and on the left side it will extend from this point, the mid of the fourth costal cartilage, to the sixth costal cartilage on the left of the midline. But the lung will deviate more lateral, as you can see in this yellow star. It will deviate more lateral because here you have a cardiac notch in the anterior border of the lung. So it will deviate 2 centimeters lateral to the border of the sternum, more lateral than the sternal reflection. The inferior border of the lung will be drawn by a line connecting the following points. We will connect the lower end of the anterior border of the lung. On the right side it will be the xiphisternal joint. Then on the left side it will be at the line 2 centimeters lateral to the cardiac notch at the level of 6 costal cartilage, and this will be connected with the 6th rib and the point at the 6th rib and the midclavicular line. More laterally it will be the 8th rib and the mid-axillary line, and more posteriorly it will be the 10th rib just lateral to the spine of T10, which means that the lower border of the lung will be 2 ribs above the level of sternal pleural costal reflections. Surface anatomy of the oblique fissure will be drawn on the chest wall by the line connecting the following. For the oblique fissure, we have to connect the point at the 6th costal cartilage near the sternum, near the border of the sternum, with the 5th rib in the mid-axillary line, and finally with a point 2 centimeters lateral to spine of T3. While the horizontal fissure, which is only present in the right lung, will be drawn by a line connecting a point which is the 4th costal cartilage near the sternum till meeting the oblique fissure in the point which is at the 5th rib in the mid-axillary line. The trachea divides at the level of sternal angle of Lewis into right and left branches that are called main primary bronchi. These main primary bronchi will divide further. On the right side, the main primary bronchi will divide into 3 secondary lobar bronchi, one for the upper lobe, the other for the middle lobe, and the other for the lower lobe, while the left main bronchus will divide into 2 secondary lobar bronchi. And each of the secondary bronchi on left and right side will form segmental bronchi, which are the tertiary bronchi. And the segmental bronchi will be one for each of the bronchopulmonary segments that we had just described, the functional units of the lung. And thus, the bronchopulmonary segments have names that are the same names of the tertiary segmental bronchi, and having the same number also. So you'll have 10 tertiary segmental bronchi on the right side and 8 on the left side, divided into each of these tertiary segments. Bronchi will be one for each of the bronchopulmonary segments. And again, you can remember the name of the tertiary bronchi and the name of the bronchopulmonary segments from the diagram. Blood supply of the lung is derived from the bronchial arteries, which are branches from the descending aorta and are branches of the posterior intercostal arteries. Venous drainage of the lung will be to the azygos vein on the right side and the hemiazygos vein on the left side. Lymphatic drainage of the lung will be toward the bronchopulmonary lymph nodes. Nerve supply to the lung is autonomic, which is parasympathetic from the vagus nerve, which is the 10th cranial nerve, and sympathetic from the thoracic sympathetic chain. Thank you very much.